Hi, this is acute respiratory distress syndrome. So, acute respiratory distress syndrome is a specific type of hypoxemia and respiratory failure that occurs in both lungs. And it first was recognized in the 1960s, and it was during the Vietnam War. And what they saw were they had patients. See, back then you were able to save patients at a greater rate, really sick patients. But what happened was a lot of them, because of blood loss and injuries in the field, the patients had developed shock, okay, and then they didn't really know exactly what was going on, but they also developed later on this terrible respiratory distress problem. And so they named it shock lung, which I've always really liked that name because it usually happened in patients who had severe hypovolemia. The hallmark of acute respiratory distress syndrome is that the capillary permeability is really leaky, okay? And so a lot of fluid and stuff gets into the alveoli and you don't get diffusion of oxygen across that membrane. And then eventually the other thing that happens is through the process of trying to clean that up, you end up with scar tissue in the lung. Now, from this slide here, you can see that there's direct causes of respiratory distress syndrome, and those are all to do with lung injuries. So aspiration, which is a huge one, we see this particularly in patients who have, G tubes or NG tubes in place or who have aspirated during surgery. People who have had toxic inhalations, near drownings, pneumonia, oxygen toxicity, thoracic radiation. So things that happen to the lung themselves are direct injuries. What's interesting is that an awful lot of patients with acute respiratory distress syndrome have indirect injuries. This means they have a problem somewhere else, and as like a little added bonus, they end up with acute respiratory distress syndrome. So, for example, sepsis is one of the bigger culprits. So patients who are septic, and it can be sepsis anywhere. They may develop acute respiratory distress syndrome. People who are on cardiopulmonary bypass, who have embolisms, who have DIC and who are in shock are also at risk for developing acute respiratory distress syndrome. So acute respiratory distress syndrome occurs because there's been an injury to the lung or because it's a complication of a disease process, okay? Gastric aspiration and septic shock are associated with 25% of ARDS patients. So patients who have gastric aspiration or who have had septic shock, you always kind of need to keep yourself aware that this is a potential complication for these people. With ARDS, we have three distinct phases. There's the first phase, which is the exudative phase. Then there's the prolific phase, and then there's the fibrotic phase. And the thing you need to recognize is that 50% of ARDS patients will not live. So the whole thing to think about is to recognize this quickly and treat it, and always be on alert for it in those patients who are at risk for it, and then to try to get the patient back to as normal a state as possible. So the first phase is when injury or exudate begins, and it usually occurs 24 to 48 hours after either the direct or indirect injury. And what happens at first is it sets up a situation where you get an incredible amount of inflammation. When the inflammation occurs, the alveoli and capillary membrane become damaged. And with that, you have increased capillary permeability. In other words, things get very leaky. And when that happens, this microvascular injury damages the alveoli, and fluid enters the alveoli. When the fluid enters the alveoli, it dilutes the surfactant. So surfactant keeps the alveoli open, But this fluid that enters the alveoli waters that surfactant down. And what happens then is the alveoli stiffen and collapse. So you can understand how people who have collapsing alveoli have declining oxygenation. What you see is interstitial and alveoli edema. Okay, you'll get atelectasis and you'll get non-cardiogenic pulmonary edema. In other words, the patient will develop pulmonary edema, but the cause is not heart failure, it's because of the ARDS. What then will happen is you'll get what's called an intrapulmonary shunt because of increased in alveoli fluid. You'll get hypoxemia, and the patient will become resistant to oxygen therapy. In other words, no matter how much oxygen we give this patient, we will not see an increase in or an improvement in their condition. Now, one of the reasons we're seeing all this fluid is because there was an initial injury, and then on top of that initial injury, an inflammatory process, you have cells trying to flood the area to clean the mess up, and it's just sort of making a bad situation worse. So if the patient can be stabilized through this period of time when the initial injury occurs, they then go on to the second stage. So now I'm going to draw what happens. So what happens to the patient is, here's your little alveoli, all right, and there's the nice little skinny membrane that it usually has. And so, as you can see, I can't draw that well. But anyway, as you see, you have nice oxygen molecules in here, and that oxygen is able to go through the membrane of the alveoli to the capillary, and that oxygen gets delivered to the blood, and everybody is happy. Now, what you have with ARDS is you have an alveoli, okay, and you have damage. So what you get is this big thickened membrane and then all this fluid on top of it, okay? So the membrane gets damaged, and then you have all this fluid, okay? And then here's the poor little oxygen molecule here, okay? It has to go through all of this foolishness and into the membrane in order to go into the nice little capillary that's just very pleasantly waiting for it. So there's too much fluid for the oxygen to go through in order for it to be picked up in the capillary bed. So 1 to 2 weeks after the initial insult, you have an inflammatory response. This actually is there to help clean up the mess. But what happens is you have fibrin and cell debris from necrotic cells form this thing called a hyaline membrane, and the lungs themselves become fibrotic. So now, instead of having to go through all this fluid, the CO2 cannot diffuse across the hyaline membrane. And what you see is the PCO2 rises, and the patient ends up with respiratory acidosis. This phase is complete when the diseased portion of the lung is very dense and fibrous tissue. If the patient survives, they go into the reparative phase. If we can stop the fibrotic tissue from forming, the patient has a better chance of survival. So during the fibrotic phase, that's the third phase, that's 2 to 3 weeks post initial insult, okay? It's also called the chronic or the latent phase. You have scar tissue forming in the lungs and fibrosis, and that means you have lung compliance, and the patient isn't going to get this back. So what this means is you have decreased surface area for gas exchange, and the hypoxemia continues. So you could have a patient who goes into the hospital without any kind of lung disease, aspirate, and then end up with decreased lung compliance permanently. And what usually happens is these patients develop a permanent pulmonary hypertension. They end up sort of developing permanent pulmonary problems, and a lot of these patients have metabolic acidosis, and that metabolic acidosis will lead to multiple organ system failure. So in other words, this is like a really bad slippery slope where you have the patient develop a really bad initial injury, and then complications of this injury, which is a metabolic acidosis, causes the patient's other organs to shut down. And this is what usually is the thing that causes the patient to die. It's not necessarily always the lung injury, but oftentimes it's these other complications from the multi-organ system failure. So that was the pathophysiology, but remember, we have a patient to treat, so what's that patient going to look like? So at first, when we say it's an insidious onset, it develops between 24 and 48 hours after the initial injury. And how well the patient does, or the course usually is determined by the nature of the initial injury as well as any other comorbidities that the patient may have. 50% of patients who develop ARDS die, even with very aggressive, very intensive medical treatment. So what does the patient look like? Well, what's interesting is that at first there's not too much going on with the patient. So early symptoms might be the patient has a little bit of dyspnea, they might be have a little bit of an increased respiratory rate. Oftentimes they just they don't feel well. They'll say, you know, that something's wrong, but they don't necessarily have any clinical symptoms that would lead us to believe they're having a respiratory problem. A lot of times we'll go in, the patient's on the call bell a couple of times, and we think, oh, the patient's anxious. They're a little restless. If you were to listen to their lungs at this point, you wouldn't hear anything significant, okay? And their O2 sat would be okay. They also might have a dry, non-productive cough, so they wouldn't even be coughing up any fluid. So this wouldn't necessarily lead you to believe that they are developing ARDS. It isn't until later on where we start to see symptoms on the patient, and when the patient might have some adventitious breath sounds or begin to use accessory muscles to breathe or have a decrease in mental status or orientation or maybe even cyanosis, that we really can see anything clinically. One of the things that is significant is this patient might complain of vague respiratory symptoms, but even though you give them more oxygen, it doesn't improve their status. So when things get really bad and people start to put more oxygen on the patient, and maybe we move from nasal cannula to something more significant like face masks, no matter how much oxygen you give this person, you won't see an increase or you won't see it improving their O2 status. They develop non-cardiac pulmonary edema. So then we have lung sounds that are filled with, rales throughout and patient coughing up pink, frothy sputum. So in the next slide, you're going to see what an X-ray looks like with ARDS. They have what's called whiteout or a snowstorm effect, where they have an incredible amount of lung tissue that's just filled with fluid. Pulmonary artery wedge pressure is 18 or higher, and there's no evidence of heart failure. So this isn't a patient who's not a heart failure patient. And so this is the chest x-ray. So this is actually the chest x-ray of the same person. So this is before the patient developed the ARDS. Okay, you see all this black area here. This means this is decent lung tissue. And then this here is all whited out. Okay, so everything that's all gray or whited out here is lung tissue that's been damaged. And if you look right here, you only see these little teeny tiny spots of lung that look to be viable at this point. And when you look at this, you can see if all of that lung tissue becomes fibrotic and non-viable, the patient is really going to be compromised, and it's going to be unlikely this patient is going to do well.